Good evening, everyone. My name is Jackie Dominguez, and on behalf of the American Liver Foundation, I thank you for joining us this evening. The mission of the American Liver Foundation is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease, and the academic debates is one of our signature programs. When we hosted last year's debate, we gathered in person, but that's not possible this year. So we welcome you to our virtual event and encourage you to use the chat feature so we can get to know who is with us. In the chat box, tell us who you are, where you're from, and please don't be shy about giving shout outs to your favorite team or institution. Before the debates begin, I'd like to take a moment to thank those who donated when they registered. And now it's my privilege to recognize our national and local Michigan debate sponsors. The American Liver Foundation is grateful for the support received from National Gold sponsor ASI. Matt Johnson, Jim Wolf, Olga Teneko, and Kimberly Friel have joined us this evening. National Bronze sponsors Salix with Representative Chris Sirhan and Diana Higgins, and CVS with Brenda Karakian. Our national partner is Mallinckrodt, and Sheila Komara has joined us this evening as well. Now let's turn our attention to videos from our national sponsors, ASI and Salix.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs. And we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications. Because our mission to improve the care for GI patients continues today. For us, there is no finish line.
The American Liver Foundation is grateful for the local support from the following Michigan sponsors. Our local premier advocate is Gilead Sciences, represented by Rachel Kuss and Aaron Marsh. Our participating advocate is Intercept Pharmaceuticals. Frank Schumacher has joined us this evening. And one of our newest partners coming in at the exhibitor level is Alnylam, represented by Lisa Beardsley. They'll be chatting with you later on in the chat box today. And now a few words from Rachel Kuss from local premier advocate, Gilead.
Good evening, everyone. My name is Rachel Kuss. I'm a hepatitis C senior therapeutic specialist with Gilead Sciences, And along with my Michigan colleagues, John Goba, Jody Gollin, Aaron Marsh, and my hepatitis B counterpart, Laura Horner, we just wanted to say hello to everyone, and we're excited to be here supporting this awesome event with the ALF, even though it might be virtual this year. As you all know, Gilead Sciences is a research-based biopharmaceutical company that discovers, develops, and commercializes innovative medicines in areas of unmet medical need. For 20 years, Gilead has been working to transform the treatment of liver disease. You can visit our product website, hepcinfonow.com, to learn more about the treatment for hepatitis C, and visit our product website, hepb.com, to learn more about treatment for hepatitis B. Good luck to all our debaters, and see you all soon.
We truly appreciate the support of all of our sponsors. Thank you so much. This concludes our reception, and we will move on to our educational program for this evening. I'd like to begin by thanking our course director, Dr. Kimberly Brown of Henry Ford Health Systems, our moderators, teams, Q&A faculty panel, and the ALF team of Kat Evans, Lindsay Ventura, and Donna Shaka. And now I'd like to introduce our co-moderators for the evening, even though they need no introduction. Not only are they serving as co-moderators, they are mentors of their respective teams this evening as well. Both of our moderators are considered key thought leaders in Michigan and beyond. Their impressive bios can be found on the ALF website, along with the bios of all of our debate team members. It is now my privilege to hand the program over to Dr. Rina Salgia of Henry Ford Health System and Dr. Hari Kanjivaram of the University of Michigan.
Thank you, Jackie, and good evening, everyone. Thank you all for joining us. It's been my pleasure for the past 3 years to serve on the planning committee for the American Liver Foundation's Michigan Academic Debates, along with my former program director, my role model and friend, Dr. Hari Kanjivaram from the University of Michigan. To the audience, we appreciate your participation, especially during this time of understandable challenges for many and trying to juggle commitments both at work and at home, and also during this holiday season that's upon us. Although we would have wished to have gathered in person, it is truly a testament to our collective strength and support of the medical community and our educational programs that allows us to continue this event tonight. So thank you for being with us. We are excited to share with you the hard work and efforts of our 3 teams tonight: Ascension Providence, Henry Ford Hospital, and the University of Michigan. Importantly, recognizing that these programs all participated last year as well. Before Dr. Kanjivaram makes his remarks, I would like to introduce the debate topic and the significance of this topic to our community and beyond. Tonight, the debate will focus on the topic of direct-acting antiviral or DAA therapy among ongoing or active drug users. Prior to turning our attention to the COVID-19 pandemic, the country was struggling with and continues to deal with an opioid crisis. The past decade, there has been a coinciding sharp increase in the incidence of hepatitis C, especially among young adults. And this has resulted in a growing body of literature on this topic, as well as changes in the recommendation for HCV screening. Our teams will debate the role of DAA therapy in active drug users. And now I'll turn the screen over to Dr. Kanjivaram.
Good evening, everyone. I'd like to join Dr. Rina Salgia in welcoming everyone to this remarkable program. I'll be providing a brief overview of the criteria for this evening for everyone. We'll be hosting an exciting debate featuring 2 teams, as Rina mentioned, one from Henry Ford Health System and Ascension Providence. Our goal through this debate is to stimulate a deeper look on a significant issue that has impacted the lives of many people with chronic liver disease. And in this case, tonight we'll be talking about chronic hepatitis C. The debate teams worked on the following, just for you all to know. The presentation content and the organization, the presentation and rebuttal skills, use research supporting their position. They'll also be responding to the questions as well. And we'll also be assessing their overall style and their delivery as well. As mentioned earlier, the format we're using today is different from other debates, as many of you might have attended already. Our team from the University of Michigan will be serving as a faculty Q&A. Instead of actually faculty, we'll actually have two fellows to play this role. We think it's very important to encourage and inspire our fellows during their training. They have researched both the pro and the con positions as well, and they will be asking appropriate questions to both the teams regarding their presentations. In the state of Michigan, we prefer to think that all our teams are as winners, so this format lends itself to that philosophy as well. As I mentioned, it's our hope that this evening will stimulate greater passion and enthusiasm for the field of hepatology, even if you all don't take part in keeping this as your main field of interest in the long run. This is mainly for the our fellows. The idea at the end of the day is to provide the best care for our patients. So please do keep that in mind. I'd like to say a few words about the program. For those who haven't joined these debates in the past, this program was developed by the Great Lakes Division Medical Advisory Committee. I believe it's been more than 17 years ago. It has since been adopted by AASLD. And this is our third year of debates in Michigan. The slide you're viewing represents the three teams, the participating institutions, the Ascension Providence, Henry Ford Health System, and the University of Michigan. The planning committee has developed this topic and this modified format I previously mentioned. The goal is not to necessarily come to a consensus whether this topic is right or wrong, but hopefully we can address a controversially, but yet we think a very clinically relevant topic on an issue pertaining to liver disease treatment, best practices, and new research in hepatology. We hope to stimulate progressive data-driven thought among those who treat liver patients, and also showcase the talents of our incredible GI and hepatology fellows. In this regard, I would like to acknowledge the very thoughtful efforts of the team mentors, Dr. Pratima Sharma, Dr. Mark Piper, Dr. Rina Salgia, Dr. Stuart Gordon, and led by our course director, Dr. Kimberly Brown, who could not be here today. At this time, I would also like to mention that all of us have the opportunity to support the mission of the ALF. And throughout the course of this program, we will see a donation link appearing periodically in the chat. We can click on it. I think it's a wonderful way to support ALF to continue to bring education to our healthcare professionals and to our patients as well. Before we introduce the teams, I wanted to mention that the presentations, the rebuttals, the Q&A are timed. By our ALF timekeeper. This will be electronically reminding the debaters about the remaining time. And this is very important to keep in mind. Please pay close attention to the reminders, the debate teams, because the microphones will be shut off when time expires and the speaker will not be allowed to finish their remarks. So please do keep this in mind. We want to hear everything that you want to say. We ask our audience to chat and tweet during the debates. And if you have any questions, feel free to include them in the chat. The Q&A panel has prepared questions, and time remaining during the session, they will be asking your questions as well.
So the debate will be fast-paced. We will start each debate with the pro presentation, followed by the opposing con presentation. Each side is going to be allotted 8 minutes, as you see on the slide being shown, to present their argument. Should a presenter exceed his or her 8 minutes, our timekeeper will disconnect their audio and video, but we will do our best to transition smoothly from one presenter to the next to keep the program flowing. After both arguments have been presented, each side will have the opportunity to challenge their opposition with a 5-minute rebuttal. And again, this will be closely timed. A 20-minute question and answer session will follow the rebuttals. We definitely want this debate to be interactive, so please use the chat feature to pose questions to the debate teams. And if time permits, following the judges' questions, we will bring your questions forward. So with that, I would now like to introduce the fellow Q&A panel from the University of Michigan. Dr. Dempsey Hughes and Dr. Abhishek Satish Chandran will be serving as the panelists and were mentored by Dr. Hari Kanjivaram and Dr. Prathima Sharma. And next, it is my pleasure to introduce our Ascension Providence debate team. From Ascension Providence, under the returning mentorship of Dr. Mark Piper, the debate team will feature Dr. Fadi Alali and Dr. Arij Mazhar.
And it's my privilege to introduce the Henry Ford Health System team under the mentorship of Drs. Rina Salgia and Stu Gowden. The team features Dr. Ahmed Elbana and Dr. Vivek Mandarata. Let's start the debate with Dr. Arik of Ascension Providence. He's presenting the pro position. It'll be 8 minutes. The faculty Q&A team, please pay close attention to this. The timekeeper is ready. Let's begin.
Hi, my name is Arij Mazhar, and I'm a first-year GI fellow at Ascension Providence Hospital, and I'm taking a stance on pro-viral hepatitis DAA therapy for active drug users. Firstly, we would like to thank the American Liver Foundation and our counterparts at the University of Michigan, as well as Henry Ford Hospital, and all of the colleagues and mentors who helped put this presentation together. So we believe that we should treat all active drug users with DAA therapy, and I'll show you why. Firstly, treating patients who inject drugs who have hepatitis C infection decreases the burden of disease in the United States as well as in the world. It is cost-effective, and the SVR and adherence rates are similar in this population compared to non-injection drug users. I will also show you how this impacts population health as a whole in an effort to eradicate hepatitis C worldwide. So first, we will talk about the cost and burden of disease. So what is the burden? In this survey from the CDC, looking at the past decade, we see that there is a drastic increase in the estimated number of acute infections of hepatitis C within the United States. When we look across all age groups, we see a similar drastic increase in the number of reported acute hepatitis C infections within all ages. But most importantly, we see that this is a growing problem within the younger age group. And this is important because younger patients are sicker longer and costing us more healthcare dollars. So when we ask ourselves, who is the burden? And when we look at the etiology of hepatitis C, we see that injection drug use constitutes of about 60% of those patients who have acute and chronic hepatitis C infections. Increased burden is equivalent to increased cost. And we see that there have been a greater than 250% increase in hospitalizations related to hepatitis C from 2005, which is costing us more than $500 million annually. You may ask, what is the cost? Multiple studies from the Netherlands, the UK, and Australia have delved into this topic. This study from the Netherlands looked at increasing stages of fibrosis from F0 to F4, as well as decompensated cirrhosis, DC, and the development of hepatocellular cancer. And we see that there is an exponential dollar increase in cost per health state with worsening fibrosis and worsening disease. So we know that this is a burden on our healthcare system and that these patients should be treated, but is this treatment cost effective? This study from Australia, looking at patients who received early treatment with DAAs versus no treatment and late treatment with DAAs versus no treatment, showed an incremental increase in quality of life years gained. So we know that the burden of hepatitis C is increasing drastically in our country and that these infections are costing us $500 million a year to diagnose and treat these patients, and that most acute and chronic hepatitis C infected patients are injection drug users. So we know that this is a burden within the United States, but also worldwide, and that it is cost effective to actually treat these patients. Let's see what their SVR and adherence rates are. This study from the JAMA network in 2020 shows us that patients with cirrhosis and without cirrhosis who have hepatitis C infection, regardless of gender, male or female, regardless of insurance type, that DAA therapy favored lower mortality across the board with significant p-values of less than 0.001. And this is important because achievement of SVR is equivalent to lower mortality. So can these patients actually be cured? We know that they should be treated, and the answer is yes. This study from Belgium in 2017, looking at active drug users, former drug users, and those on opioid substitution therapy, showed that all of these patients could achieve high rates of SVR from 83 to 93.5%. And while my counterparts may say that there is a marginal difference in achievement of SVR between active and former drug users, that is irrelevant because these patients, regardless, achieve high rates of SVR. Now, you may wonder if injection drug use more frequently also impacts SVR, and the answer is no. This was evaluated in the Anchor study, and they found that patients who injected daily or more frequently did not impact SVR with a p-value of 0.73. Similarly, lower socioeconomic status, such as unstable housing, also did not impact SVR with a p-value of 0.73. So we know that these patients can be cured, but will they adhere to treatment? The answer is still yes. Multiple studies support this. Firstly, the Anchor study shows us that office visit and medication adherence in patients who injected drugs who had hepatitis C exceeded rates of 88 to 90%. Similarly, the C-EDGE CoSTAR study showed us that 97% of these injection drug users who had hepatitis C had greater than 95% adherence to DAA therapy, and that 58% of these patients had a positive urine drug screen during this study. Similarly, another study, the SIMPLIFY trial, which was a single-arm phase 4 multi-center trial, showed an overall median adherence rate of 94% in active drug users who had hepatitis C infection treated with DAAs. And we have another study from September 2019 by Brown et al. Evaluating 2,091 patients in a pooled analysis of clinical trials, showing us that adherence rates actually didn't even matter. Patients at 8 weeks and 12 weeks who were taking DAA therapy, despite non-adherence, still achieved high rates of SVR from 96 to 99%, which is significant. This same study further went on to show us that injection drug use was not equivalent to non-adherence with a p-value of 0.83. So we have shown you that SVR improves mortality, and multiple studies show that adherence rates have exceeded 88 to 90% in injection drug users. And these studies have also shown us that even with imperfect adherence, there's no difference in achievement of SVR. And most importantly, that injection drug use did not predict non-adherence. So let's see how this impacts population health. Firstly, we should ask ourselves if we're doing enough. And the answer is no. The prevalence of hepatitis C is not just a problem within the United States, but worldwide. And when we look at the prevalence of hepatitis C among those who inject drugs, this constitutes more than 80% of the world map. The WHO recognizes this as a global problem and has targets to eliminate hepatitis C by 2030. But what do the guidelines say? The American Association for the Study of Liver Diseases and the Infectious Disease Society of America, in a joint statement, clearly and frankly state, active or recent drug use or a concern for reinfection is not a contraindication to hepatitis C treatment. Similarly, the European Association for the Study of Liver Diseases states that the patients who inject drugs who have hepatitis C infection should not have any barriers to diagnosis and treatment. And if they do, all of these barriers should be removed. So in summary, we have shown you that the burden of hepatitis C is increasing drastically, not only within our country, but worldwide. There is no statistical significance in achievement of SVR between those who are actively using drugs or injecting drugs and non-drug users. Adherence rates to DAA therapy in those who are using drugs and injecting drugs exceeds 90%. DAA treatment is cost-effective, improves mortality, and increases quality of life years. And I will leave you with one final thought. If this was your family member, your father, your brother, your mother, your sister, your son, or your daughter who is suffering from an addiction to IV drug use or active drug use who had hepatitis C infection, wouldn't you want them treated and cured? Thank you.
Thank you, Dr. Mazar, for a very, very strong presentation. It was awesome. I'd like to now invite Dr. Ahmed Albana from Henry Ford. He will speak to the Khan presentation. You'll have 8 minutes, Ahmed.
My name is Ahmed Al-Banna. I'm one of the first-year fellows at Henry Ford Hospital. And today, over the next 8 minutes, I'm going to take off those rose-colored lenses and I'm going to bring you back to the real world. My colleague Vivek Mendarada will be presenting our rebuttal today. I'd like to thank my mentors, Dr. Gordon and Dr. Salgia, as well as the American Liver Foundation and their sponsors for putting this together. I'd like you all to consider the following case. You have a 29-year-old female with a history of HIV coming to your clinic with diarrhea. She's unfortunately uninsured, homeless, actively using drugs, and sharing needles. A comprehensive workup reveals that she's Hep C positive with. Give me 1 second here. Apparently, we're having some technical difficulties. Okay, so bringing you back to the real world, I'd like you to consider the following case. 29-year-old female with a history of HIV who presents to your clinic with diarrhea. Unfortunately, she's uninsured and homeless. She's actively using drugs. She shares needles to save money. And a comprehensive workup reveals she's Hep C antibody positive with an RNA of 100,000 and genotype 3. So the question is, would you treat this patient's Hep C infection at this time? This patient falls into a category for which I would like to define as high-risk people who use IV drugs. This is a population who are significantly less likely to benefit from DAA therapy. That's because they're not receiving opioid substitution therapy, they're actively using drugs, and they're sharing needles. Our argument is that this subpopulation should not be treated with DAA therapy. It's pretty clear that they have lower rates of SVR, and even if they do achieve SVR, they're at increased risk of reinfection. Instead, we advocate a more compassionate use of resources focused on addressing underlying addiction. That's because the cost of DAA therapy can be significant and barriers to Medicaid reimbursement for DAA therapy in this population persist. I'd like to highlight the HERO trial. This was oral presentation, late-breaking abstract in AASLD, and the following slides are directly from that oral presentation. Multi-center trial, 25 sites, 8 states. In order to be enrolled, patients had to be actively using IV drugs within 12 weeks of study entry. Everybody was treated with sofosbuvir and velpatasvir, and these were treatment in community-based clinics. So all patients were DAA treatment naive. They were randomized into one of 2 treatment arms, either the modified direct observation treatment arm, where patients were observed directly or via video conferencing software, taking their medications, versus a patient navigation arm when they were on their cell phone, indicating that they were taking therapy. And the punchline here is these patients achieved 60% SVR on intention to treat analysis. You don't have to adjust your screens, not an upside down 9. This is real world data. This is data that's relevant to clinicians. And this is the data that we need to be considering when we are asking ourselves if we should treat that 29-year-old female. In addition, they took a look at some subgroup analyses and looked at patients on opioid substitution therapy, of which, so there's total 755 patients, 70% of which were on opioid substitution therapy. They compared methadone to buprenorphine. Methadone is a full opioid agonist and buprenorphine is only a partial opioid agonist. And it was clear that less potent opioid agonist therapy resulted in lower SVR. In addition, they looked at how recent patients used IV drugs. And again, if they used IV drugs within 4 weeks of study enrollment versus 5 to 12, it was clear they had lower SVR. And by the way, they also looked at how frequently they used IV drugs. And if they used IV drugs greater than twice a day, they were also significantly lower SVR. So this begs the question, what is the goal of our therapy? Is it to achieve SVR? Well, I certainly hope not, because as you can see, the rates are abysmal. What about to prevent transmission of infection or to prevent chronic infection? This is a study in clinical infectious disease that was published in 2020. And it took my colleagues' patients from the Simplify and Defeat trials, and they followed them for 2 years and took a look to see if they developed hepatitis C infection again, if they were reinfected. Long story short, there was statistically significant reinfection rates in those patients that shared needles. That makes sense. This is another trial, a large cohort trial from Canada, and it looked at patients that achieved SVR following treatment and followed them for 72 weeks and compared their risk of getting reinfected with hepatitis C. And guess what? Recent IV drug users were at significantly increased risk of getting reinfected. So back to our goals of therapy. Well, I've shown you that achieving SVR, not really great. 60% is abysmal. And if these patients are getting reinfected and they continue to use IV drugs and they continue to share needles, they're going to continue to transmit infection. And if they're getting reinfected, obviously we're not preventing chronic infection here either. So we're really not doing too well with our goals, are we? Now, unfortunately, this study population faces many challenges. One of those challenges that they face is most are underinsured or uninsured. That means in order to achieve care or get care here in the United States, they rely on Medicaid, which is a limited resource of US tax dollars. Cost of DAA therapy is not cheap, and even less cheap or more expensive is if they fail that initial treatment, which as you can see, 40% of patients will, they may require even more expensive treatment for possible resistant infection. So instead, these valuable resources should be directed towards increasing access to care and addressing their underlying addiction, which is the real problem. We should invest in education, we should invest in opioid substitution therapy, as well as syringe service programs or needle service programs. This is a very large meta-analysis, public health data from 4 countries, England, Wales, Scotland, Australia. And not only did they demonstrate that NSP and opioid substitution therapy significantly decreased patients' risk of developing HCV infection, they demonstrated that investment in these strategies is significantly cost effective. In just 4 cities across the UK, they demonstrated over a £40 million benefit over 2 years. What about barriers to Medicaid reimbursement? They still exist. This is what patients rely on to get treatment. This is the real world. This is not a study that we are treating. We're treating patients in the clinic. And as you can see on the image on the left, there are still significant barriers based on fibrosis staging of the liver in order to get reimbursed for DAA therapy. In addition, what's more concerning is the image on the right, which demonstrates, again, significant barriers based on abstinence of IV drug use in order to get reimbursed for DAA therapy. Just in Michigan alone, as you can see, you're required to have F2 fibrosis and abstain from IV drugs, or any drugs actually, for a 6-month period. So in summary, treating high-risk people with IV drugs with DAA therapy is not effective. The SVR rates are just unacceptable. There's considerable risk of reinfection, and treatment failure is potentially associated with resistance. Instead, investment in established methods to decrease infection risk in this population should be employed prior to consideration of DAA treatment. We should be advocating for improving Medicaid reimbursement for DAA therapy in people who use IV drugs that have favorable outcomes to getting treatment success. Thank you so much for your attention.
Thank you, Ahmed, for a beautiful rebuttal, a great presentation and comments as well that you made. Now we will like to introduce Dr. Fadi Alali of Ascension for the pro rebuttal. Fadi, you have 5 minutes.
Thank you, Doctor. My name is Fadi Alali. I'm a second-year fellow in gastroenterology program at Ascension Hospital. I would like to thank the faculty and the staff at the ALF for arranging this scientific meeting. And I would like to also extend our thanks to our colleagues at Henry Ford Hospital for their presentation. As we all know, the WHO had set goals by 2030 to diagnose up to 90% of patients with HCV and get 80% of the patient treated and decrease mortality by 65%. In order to get this goal achieved, we have to target the patient who inject drugs and have HCV, as this group of patients can account for at least 30 to 40% of the patient infected with HCV in the country. Now, the treatment is highly effective. And I don't know, I mean, probably the counter team came up with 1 studies, but like we have tons of studies showing the SVR rate is very high, exceeding 90% of the time. What are the concerns or physician can go through when they treat such a group of patients? Adherence and response rate. A lot of studies have shown that adherence is as high as 90%, and the SVR is as high as 90%, if not better. And the CH CoStar study did show more than 90%, above 95% response rate. The studies that showed less adherence rate had some limitations, including a small volume of these studies, and also the patients that recruited by the studies, some of them were incarcerated or admitted to the hospital for some time, and they were not able to account for adherence accurately. The studies that came up with less optimum SVR accounted for patients who were already recruited when they were on the interferon, and that's what also affected the SVR. But in general, the DEAs are highly effective. The other concern is the reinfection. it's a real concern. But once these patients relapse to IV drug abuse, they have the risk of reinfection. Reinfection doesn't mean treat always, because some studies did show that there's a small percentage of patients can clear this reinfection spontaneously. And more studies needed in the future to find out what are the factors that can be associated with the spontaneous clearance of this reinfection. The rate of which I wanted from our colleagues just to go over like more rates for the reinfection. The reinfection rates are really low, like between 2.5 all the way to 6.5 per 100 person year. As the studies that came up with a higher reinfection rate had some limitations. These studies were not done on the OST, the opioid substitution therapy, or some of them, they did not do genotyping or sequencing to differentiate between the relapse and the reinfection, and that end up with overestimation of the reinfection rate. How do we prevent? So for sure, providing the patient with clean needle and syringes, providing them with the OST is very important to decrease the risk of reinfection, but that's not alone enough. If we combine these two strategies with the DEAs, according to one study, we can decrease the risk of prevalence of HCV, decrease it more than 50% for the next 10 years. Also, one of the strategies besides education, also including their partners, whether sexual partner with rescue behavior or the partners who share injections with them. These should be shared for diagnosis and treatment. So in general, and then at the end, I want to end with this. I did a lot of like literature search. And then after the presentation from our counter team, there's no study had shown that withholding treatment from this group of patients will end up with any benefit. Until time comes and this study, which goes against the guidelines, show us to stop treating this patient, we should all treat hepatitis C patients who inject drugs with DEAs, as this treatment is highly effective, curative, cost-effective, and will stop the prevalence of this disease. And thank you.
Thank you, Dr. Alali. Great comments for the rebuttal. Now I would like to introduce Dr. Vivek Mandirata from Henry Ford for the Khan rebuttal. Please.
Good evening, everyone. Before we get to my counterpoints, I wanted to again reiterate a thank you to our mentors, to Providence Hospital, as well as the American Liver Foundation for putting on this debate. Now, the affirming team really tries to sell us on this treat all philosophy and the circular argument that we should be treating high-risk patients. It hinges on this theoretical public health benefit, and they're making these grandiose projections of where we'll be in 2030. But their studies are largely flawed for a number of reasons. First and foremost, they can cite study after study after study, but the majority of their studies have an inherent bias in that they're selecting for the absolute most compliant patients, i.e. these are the best of the best when it comes to IV drug users. These are patients that have been recruited, they've signed informed consent, and in general are highly motivated to complete treatment. In the HERO trial, which was not interferon-based, as Fadi said, which was on about DAA treatment, participants were actually paid to be enrolled in the study. They were reimbursed $20 for every research visit for up to $400 to participate in the study. Furthermore, once selecting for this already more compliant population, they couldn't have possibly made it any easier on these patients. These patients had numerous regular interval follow-ups. They had their medications dropped off at their door, et cetera, et cetera. The list goes on. And we really have to, it really begs the question, how real world applicable are the studies that they've shown us? We would argue that the HERO trial, which Ahmed had shown previously, is the most real world applicable study that has been presented so far. The thing is, even still with all of this being done, they have very high dropout rates, up to 20% quoted in some studies, and disturbingly high reinfection rates. The reinfection rates, which really brings me to my second point, the reinfection rates are likely underreported. Remember, the endpoints for their studies are 24 weeks, a few months, rarely up to a year. We have literally no idea what these patients are doing 5 to 10 years down the road. If they continue to employ high-risk behavior, how many of these patients will have reinfection or relapse in 5 years? And, the affirming team is very cavalier about this whole idea. They try to convince us that, that it's not a big deal, that, they may retreat the patients later, or that the infection will be cleared spontaneously. But the truth is that we really just don't know what the long-term implications of these high reinfection rates are. What we do know is that viruses mutate. That fact is undeniable. There's already data on NS5A resistance-associated substitutions, and we know that non-compliance breeds more of this. Not only that, but this is a population that is likely to spread these resistant strains to other people. Just think about how many decades of work and effort and research has gone into getting these highly effective DAA treatments. You have to ask yourself, really, are you willing and comfortable with the affirmative team's highly risky and not well-studied solution of essentially handing out DAA medications like it's candy and risking reinfection and resistance? And look, we're not these horrible people, that don't care about the poor or the unfortunate. What we are saying is that by treating the hepatitis C, we're essentially just placing a very expensive Band-Aid on an actively bleeding wound. We're not actually attacking the root cause of the issue. Remember, the main reason these patients actually die is from overdose, suicide, and comorbid infections such as HIV. Hepatitis C and liver disease does not even account for 10% of all deaths in these populations and does not crack the top 5 according to the WHO. So what exactly are we doing to help these patients? Are we just treating a number? Instead, according to our plan, we would initially refocus funds into clean needles, supervised injection sites, rehab costs, et cetera, et cetera. Once these high-risk patients have shown a commitment to sobriety and are no longer high risk, that is when we would treat them. As unfortunate as it is, resources are finite, and the affirmative team's plan does not grasp this concept. Instead, our prioritization method of treatment allows for the best chance to treat the hepatitis C once and for all. Thank you.
Thank you, Vivek, for a great rebuttal. Thanks to all the 4 debaters. Now it's time for the fellow panel Q&A from the University of Michigan team, Dr. Dempsey Hughes, and Dr. Abhishek Satish Chandran. If time allows, as I mentioned earlier, they will include questions from the audience as well. Dempsey and Satish. Abhishek, I'm sorry.
Thank you, Dr. Kanjivaram. Good evening, everyone. I'm Dempsey Hughes. I'm a transplant hepatology fellow at the University of Michigan, and I'm joined by
Abhishek Satish Chandran. I'm a first-year GI fellow here at the University of Michigan.
And we're going to be guiding the Q&A portion of this event. We'll start by asking some questions that we've prepared for the debate teams and then open up for questions from the audience. So please use the chat feature to submit your questions and then participate in this event. First off, I think it's really important to just tell the debate teams that you did a terrific job preparing and delivering these thoughtful arguments that pertain to an area with no shortage of scientific, clinical, and ethical conundrums, and you both made some very strong points. My first question is for the Ascension team, and it's on the topic of cost analysis. So I appreciate the argument that you made about potential cost savings that can be achieved by curing this patient population of hepatitis C. But it would seem that a key component to achieving high rates of SVR is having patients actually enroll in the program in order to treat them. Several studies have described barriers to screening and treatment for hepatitis C among patients who actively use drugs, including patient fears of poor tolerance or safety risks from DAAs, limited insight into severe consequences of progression to advanced liver disease, or low health literacy in general, which can contribute to loss to follow-up and treatment failure. I believe the cost estimates you cited largely consisted of specifically treatment costs. Did you consider accounting for recruitment efforts or retention strategies in your cost analysis, or did you not consider these to be of substantial cost?
All right, I think I'm not sure about the data in that exactly in that study, but yeah, I mean, for sure, like including these, it should be these costs should be included in the cost for these studies. The study that Arij mentioned, it has an interesting point that they went over the Australian cost-effective analysis. They went over two models, the early treatment and the late treatment, where they found both of them were cost-effective, but for the late treatment, they found it to be a little more cost-effective than the early treatment. I think there was a limitation in that study because they did not count for the prevention of prevalence part. Because if they would have like count for the prevention of prevalence part, they would have gained more on the ICR, and then they would probably came up with a more robust ICR in these studies. So definitely, as you say, the involvement of education involving these patients in the healthcare system definitely should be added to the cost of these studies. But down the road, I still think that these studies with the high SVR should be all cost effective.
Okay, thank you. Go ahead, Abhishek.
All right, this is for the Henry Ford team. That patient you presented initially with the HIV and Hep C co-infection, you mentioned multiple reasons why you wouldn't treat them for hepatitis C, but if they were to walk into an infectious disease clinic, they would essentially be told to, if it was to use sex protection and preventive methods, but not receive heart therapy. Would you say the same thing to them about heart?
No, absolutely not, actually. So they're two very different disease processes. And, you know, HIV, as my colleague Vivek mentioned in his rebuttal, is one of the more leading, is one of the leading causes of death in this high-risk patient population. What we're saying is we want to give these patients the best chance at treatment. I want to treat that 29-year-old female, but I want her to succeed in treatment. Our advocacy is to move these patients from a high-risk category that I mentioned. These are patients that are actively using drugs, that are not on opioid substitution therapy, and that are sharing needles. I want to move them to the moderate or lower risk group, which my colleagues described, patients that are on opioid substitution therapy. There's numerous studies. All the studies I quoted demonstrated benefit in patients with opioid substitution therapy regarding SVR and rate of reinfection. I want to get her on that. I want her to stop sharing needles. And ideally, she would stop using drugs actively. But you know, there's a group of patients that will clearly benefit from treatment, and that's patients that are not actively using on opioid substitution therapy and are not sharing needles. Patients in the middle, that's a judgment call. So my advocacy is we just want to give her the best chance of success. So I want to treat her. I want her to succeed in treatment.
All right. Next question to the Ascension team. And the topic is on reinfection risk. So multiple studies, including a large population level study from Canada published in the Journal of Hepatology in 2018, have demonstrated higher levels of reinfection among active drug users compared to the general population. Risk of reinfection has been one of the leading concerns of both providers and payers regarding utility of treating hepatitis C in patients who actively use drugs. And it's been suggested that harm reduction services are required to prevent risk of reinfection. I think you mentioned a few potential harm reduction strategies in your rebuttal, but could you please elaborate on that in terms of services that you feel could contribute to lowering the risk of reinfection?
So that is a great question. Thank you so much for that. So as I say, like involving the partners, whether they are partners in a high-risk sexual relationship or they share injections with these patients should be, the partner should be treated in case if we want to decrease the risk of reinfection. There's a program that is called Call a Friend that's mentioned by some of the studies there,
which they can like bring their partners to the hepatology or primary care clinics to be tested and to be treated if they have infection. And this way we can decrease the number of the community that they're sharing the injections with each other. And then this way we can limit the reinfection. The OST and the opioid substitution therapy and the needle syringe program, there are like great programs, evidence-based, but by themselves, they are not gonna decrease the rate of the reinfection. We are just keeping a highly risk community sharing needles and spreading the infection with them. I mean, let's keep it in mind, OST are good for people who abuse narcotics, but how about the people who abuse other sorts of substances, okay? I mean, that's not gonna help. I mean, if they are on like stimulant or other than narcotics, this may not help to control the hepatitis C. So combining these two programs along with the DEAs, as I say, according to one study, it can help to prevent the infection for more than 50% in 10 years. And that's one of the strategies. Again, we have like two large transplant centers, Henry Ford Hospital and U of M. But like, how about like in other community hospitals? We need to create satellite clinic. We need to create, give the ability to prescribe DEAs to primary cares, nurse practitioners, homeless people. They usually go to they have multiple admissions, you know, like, I mean, to the community hospitals. So having clinics belong to this community hospital that has the ability to coach these patients, educate them, and treat it, it will definitely help to keep the patient connected to the health system and treat the infection and decrease the rate of reinfection.
Great, thank you very much. To the Henry Ford team, I'd like to pose the same question and get your thoughts on what your opponents just had to say. Was there anything that you agreed with? I remember from your remarks that you really strongly stressed the value of preventive measures to actually rid the risk of infection in the first place. Were there any comments that your opponents just stated that you would actually agree with, and can we find some common ground here?
So first of all, I'd like to bring up that NSP programs by themselves, greater than 100% availability, meaning that if an IV drug user wanted to use drugs, that they had all the clean needles that they needed. That was shown in and of itself, even though the data on that isn't the greatest. That was shown in and of itself in the public health data that I demonstrated from Australia, Scotland, England, and Wales, 12,000 patients, that to statistically decrease the risk of infection of hep C by itself, as well as, obviously we know opioid substitution therapy in and of itself decreases risk of reinfection. So, I mean, I think that, you know, harm reduction strategies is of tantamount importance because of, number one, we have really good data on it. Number two, it's very cost effective. You know, and this is demonstrated over and over again in our studies. And we don't have the significant barriers to federal funding reimbursement for these types of programs that we do for our DAA therapy in our high-risk population. So I would absolutely advocate for more investment in harm reduction.
So I'd actually like to take that point to Ascension. The Medicaid, their current stipulation is that someone cannot be using IV drugs to get approved for DAA therapy, and many of these patients are reliant on that as their insurance source. How do you plan to overcome that?
I think basically as a doctor, you should be treating these patients because you take an oath to treat all sick patients. When you don't have the data also, you'd like to err on the side of treating these patients. And our counterparts actually are talking about one study, which is the HERO study, which actually stated that there was 60% rate of SVR in these patients, which I think is still significant. 60% is a big number. And I think that these patients should be treated because the opposite argument is you're just gonna wait for them to go to these needle sharing programs and opioid substitution therapy. Meanwhile, the virus is in the liver, scarring the liver. You're getting cirrhosis, you're getting decompensated cirrhosis, you're getting HCC. All of that costs money too. And you know, the cumulative cost of that compared to DAA therapy is much larger. So I don't agree with that. I think that's a barrier that definitely needs to be overcome. And these patients need to be treated because the rate of spontaneous clearance of hep C is so low, it's 10%. Its virus is not going to go away on its own. these patients need to be treated. So I don't agree with that. And I think that's actually a barrier to their care, which is unfortunate.
Okay, great. Thank you very much. My next question is for the Henry Ford team, and this is on the topic of challenges to achieve SVR among active drug users. I heard you loud and clear on your concerns about the challenges to achieve SVR in this high-risk patient population, and perhaps due to potential poor adherence to treatment or clinical follow-up resulting in potentially wasted efforts and costs. However, I think it's also important to consider the figurative costs of delaying treatment. Chronic hepatitis C is the primary etiology of liver disease most highly associated with both HCC incidence and prevalence in the US. The presence of active HCC at the initiation of Hep C therapy is significantly associated with all oral DAA treatment failure. In fact, a retrospective cohort study from Northwestern published in the Journal of Hepatology in 2017, patients with HCC were almost 8 times more likely to fail Hep C treatment than patients without HCC. So if you refuse to treat these patients at an earlier stage of disease due to concern of inability to cure their disease or loss to follow-up, it would seem like you might be setting them up for progressive disease that could prove even more challenging to treat in the setting of major complications of advanced liver disease or malignancy. So taking this perspective into account, would you reconsider treating someone earlier in their disease course to prevent treatment failure due to complications of Hep C cirrhosis and HCC?
Yeah, thank you for the great question. And, I just wanted to kind of reiterate our main point and our main argument, which is our goal will be to treat these patients. We are not advocating in any way, shape, or form to withhold treatments for these patients. What we want to give these patients the most chance of success so that once we, give them the medication, they're at a stage where they're lower risk for reinfection, higher rates of compliance so that they can treat this infection once and for all, not to, have any risk of reinfection or development of resistance. And so ultimately, we agree that these patients need to be treated, but we would like to give them the best chance for success. And we're not talking about waiting 20, 30 years down the road. We're talking about in the short term, strategies to help them, show at least some level of sobriety or some commitment to sobriety, and then, initiating treatment for these patients.
This question's back to the Ascension team. The trial I believe you cited was the Anchor trial, where patients, you showed the graph of that patients did complete treatment. However, it was noted in that trial that they took longer to complete their treatment and likely had missed doses. Given that Henry Ford team brought up that the risk of resistance will develop if people either miss doses or don't take their medication, how do you account for that when you scale this up to a larger population level beyond the small study section that was done?
Sorry, can you repeat the question?
So how do you account for, or how do you defend the potential for increased resistance when you scale up the findings of the Anchor trial, where multiple patients took longer to complete their medication and meaning they had missed doses, and likely we were exposing virus to low levels of DAA therapy, which can breed resistance?
I think that you run that risk even in non-injection drug use, non-drug use population. You don't know if they'll develop resistance. You also don't know if those patients will complete their therapy either. You just don't know. You just don't know. But you still treat these patients. I don't think that's a reason to withhold therapy from these patients. Like, oh, I think you might develop resistance, or I think you might not take your medication. I think that kind of plays into the ethics of this also, because this patient population already is so marginalized and they already don't receive the healthcare that they need. It's just like spiraling downward. If you, if you think that way, like, I'm not going to treat you because you're going to develop resistance or you're not going to take your medication. So yeah, and I think that's a real world problem. So, and that is going to happen in the real world, but you can't predict that. And that shouldn't be a hindrance to them receiving therapy.
Okay, great. Do you have a follow-up?
Yeah, one follow-up. This is back to the Henry Ford's team, you mentioned resistance as a barrier for why you shouldn't avoid treatment. However, a lot of the data shows that the predominant mutations can be circumvented with changing of drug regimens, one, and two, the NS5B mutations that occur are generally render the virus replication incompetent, which can be overcome. So with that in mind, does your argument still stand?
Yeah, so I think there's, a couple points to that. One, the resistance that we're most worried about is the NS5A substitution. That is, really bad news. And again, I think the key point here is, we just don't know what's going to happen, 5 to 10 years down the road. And the question is, in these patients who are very, likely, to continue their high risk behavior and are at risk for reinfection and noncompliance, do we want to take that chance, 5, 10 years down the road? We already have some data, albeit not specifically in IV drug use patients, but just some general data on NS5A resistance. And so the question is, what would happen in this specific patient population? And I'm just not sure that, we're willing to take that risk right now until they, undergo some sort of treatment to lower their risk of reinfection from high risk to low risk.
I agree with Vivek. I'd just like to expand. The NS5A mutations, they can last for 3 to 5 years. So in high-risk population, they're going to be spreading this resistant strain, number one. Number two, we don't have the data, as Vivek mentioned. But good news is some data is coming. So the HERO trial is actually in phase 2. They're looking at rates of reinfection as well as rates of resistance. So hopefully we'll have more on this and be able to answer this question more with data generating studies. But the answer is we don't know, but we know that, as you mentioned, that treatment can cause emergence mutations and lead to resistance.
Okay, thanks everybody. So I'd like to actually incorporate some questions from the audience to both teams. The first one is from Ashina Singh, and this is again directed to both teams. Why do you think Medicaid has so many restrictions in the Midwest?
Ascension, you can go first.
So I think regarding the Midwest, I'm going to have to scratch my brain. That was a good question, Dr. Salga. There are limited resources. The resources are limited. These are taxpayer dollars, and the government wants to ensure that we are using the taxpayer dollars as responsibly as possible. So the way that they do that is they place restrictions on these sort of treatments, and they make it very challenging for us to treat actually sometimes even populations that would benefit from treatment, as is demonstrated. And as far as why it's specifically high in the Midwest, I can only assume it's related to the population in the Midwest, and maybe that they're not as economically robust states as other states like East Coast and the West Coast. That's my best guess.
Ascension team, do you want to provide any comments here?
I think that's a great question, and I don't know why they have restrictions maybe in the Midwest. I don't know, maybe there's more racial and socioeconomic disparity, and I just don't have a good answer for that.
All right, well, let's move on to the next question. This is actually directed to the Henry Ford team. My question for the con team would be their thoughts on how we can eradicate this virus worldwide and lessen the burden on our healthcare system if we're selecting who to treat, especially considering the majority of patients with Hep C are active drug users.
So as my colleague Vivek mentioned, hepatitis C is not the leading cause of mortality in patients that use IV drugs. The real disease is their addiction to IV drugs. The Hep C is a sequela of that addiction. So we want to treat hepatitis C, but as Vivek very eloquently mentioned, we're putting an expensive Band-Aid on a bleeding wound. We need to stop the bleeding first and put Band-Aids on wounds that are going to heal. So we need to invest limited resources appropriately to give patients the highest chance of success with treatment.
and we want to treat them, just to kind of expand on that, we want to treat them. We just want to give them the highest chance of success. We're not talking, again, about 20, 30 years down the road. We're talking about a situation where these patients get treatment for their addiction. Once, they've shown some commitment to sobriety, at that point, is when we would consider treating them. And amongst, the entire population of IV drug use patients, we would treat a large majority of those patients right now. We just would not treat the high risk patients right now. So we would still capture a large portion of that public health benefit, that the affirming team is arguing for.
All right, so one question. We both presented a patient that walked into clinic, but how about a patient that was relatively well compensated? How about a active drug user with hep C and decompensated disease? What type of approach would you take with them? And this can go to both teams. Ascension can try first.
I think in an active drug user who has decompensated disease, if you're talking about decompensated cirrhosis, I think that does become a problem, especially with the social issues. And usually in patients who have decompensated cirrhosis and have hepatitis C, usually elect to treat them, after transplant. But that's a really good question you raise, because that's also the same argument in patients who have alcoholic liver disease, like should they be transplanted? Same thing with these, patients who have hepatitis C and are injection drug users. So it is a risk, but you want to prevent them from getting to that point of decompensated cirrhosis. So I know the other team is saying the highest chance of success. I think the highest chance of success is to treat them early before they progress to, F4 and cirrhosis and fibrosis and hepatocellular cancer. That's the highest chance of success. Treat them early. So you prevent this from happening, and because it is a risk to give these patients a liver, and that is an issue that I don't have a good answer for. And you just want to prevent them from getting to that point.
I would also like to add to what Arij mentioned. So, yeah, definitely. And if the wait time for the transplant is more than 6 months, we'd like to treat these patients as much as we can, instead of just leaving them alone. There are some studies showing, and back to the case that our counterpart presented, HIV. It can fasten the fibrosis and HCV patients. So definitely you need to treat these patients instead of sitting on them. So how did you suppose that the patient will be compliant to the HIV medication and they won't be compliant to the HCV medications? So that's our concern with that. So all guidelines say we should go and treat these patients instead of just waiting for them to be more compliant and then call them back to be treated.
I think, to answer that question, we would really need a lot more information on the patient specifics, a lot more layers of the patient's history, transplant status, age, concomitant alcohol, drug use, et cetera. But nothing that we've argued or said, within our presentations would prohibit that patient from receiving treatment.
Thank you, guys. Thank you, both teams. That was going to be the final question for the question and answer session. We just wanted to conclude with a couple comments. It seems that nobody here is advocating for not treating patients that are Hep C positive. In fact, that is what all of us want to do. We desire to do it. We have the tools to do so. But it very much, there's a cost-effective cost benefit to doing so. However, the Henry Ford brings up excellent points about the social constructs that are lacking in the support of these patients, as those are key elements in effective treatment and maintenance of SVR. So if we were to really say that what's needed is, yes, expanded support, more multidisciplinary clinics, advocacy on our behalf to our legislators, to provide more support for this and expanded Medicaid coverage. And a great job to both teams who presents today.
Indeed, incredible presentations. What really struck me as you guys were presenting, how passionate you are with your responses. And I think that's very, very important. I think, as we care for our patients, having that passion, advocating for our patients is so important. So thank you all so much. Dr. Salgia now makes some remarks.
Yes, thank you, Hari. I also want to echo what's been said. This was really a fantastic discussion, a very lively, very stimulating, and I think I can speak on behalf of the audience as well. The audience may not know, but we're not able as participants to see the YouTube feed. So, I imagine it's probably a pretty lively conversation there as well. But we're just so grateful to all of our participants for their efforts. And I think this was a great way to bring the three programs together, right here in Southeast Michigan, and very nice to see everybody's faces as well. So thank you, Dr. Alali, Dr. Mazhar, Dr. Mendarada, Dr. Albana, Dr. Hughes, and Dr. Satishandran for all your efforts and hard work in putting this academic debate together and your presentations. To their mentors, and then of course the support of the American Liver Foundation for hosting, and really to all of you in the audience for making this another engaging debate and discussion, and for spending the last hour plus with us. And we of course value significantly the support of our sponsors who help make this evening possible. So to remind us, we had support from AZI as our national gold sponsor, CVS as a national bronze, and Salix, of course, as a national bronze sponsor, to Mallinckrodt for the national sponsor, and then Gilead as our local premier advocate, Intercept as local participating advocate, and Alnylam as our local exhibitor. So want to thank them for their support, without which this event also would not have been possible. Hari, I'll turn it back to you.
Thank you. I think this has been a very interesting, challenging, incredible year. I always like to look at the positive from whatever bad it might look like. But clearly, as we all know, this year has changed how we look at things. One thing I do want to appreciate is that the ALF's mission has remained the same. They are very committed. And one of the things that the pandemic has done is that clearly, like other nonprofit programs, they've also had significant loss of revenue. They've been forced to change how it delivers its mission across the country, including restructuring the virtual formats. But I don't think it has actually taken away from the organization serving the patients, the liver patients, the families, and healthcare providers. I remember ALF since I was in Chicago more than 20 years ago, and one thing I always appreciated is that how many liver patients actually rely on ALF for getting the essential information, their support, guidance. I've been told that in 2020, calls to the ALF's helpline have increased significantly. There were nearly 152,000 visits to the ALF website by those seeking information on COVID-19 and other things. And also, if you have liver disease, does it affect me? I think these are relevant questions. And many in this audience have actually done some work in that regard as well. Despite all this, the ALF staff have continued to offer educational programs, supporting services and advocacy initiatives, both online this year, obviously. And since 1976, ALF has been the nation's leading nonprofit dedicated to liver health. And I think that's a huge recognition. And I think to be part of it is an incredible honor. I think it provides a voice for a lot of people with liver disease. So in this regard, we talked about helping the ALF because we're all a part of this mission for our patients. So any help that we all can give tonight to ALF, we know it will be invested in patient and professional education programs, similar to the debates this evening and other support services, advocacy, and research as well. So please consider making any a donation to help the ALF. And it is tax deductible. To finally end, I would really like to acknowledge the incredible job by our fellows. It was really very, very inspiring to see their passion, as I mentioned. And I think, we learn a lot from each other. And I think today the fellows have shown us that how much we can learn from them in so many ways beyond just the content. So thanks to each one of you for really an incredible journey in the past hour or so. Thanks again to our course director, Dr. Kimberly Brown, and our incredible mentors. Thanks to all the audience whom we cannot see. We hope you all join us in 2021 for the programs and the events. Be safe, and once again, happy holidays. Thanks to everyone. Bye.